A lot of this is because pain is complex and it's shaped by the biological, psychological and social factors that are unique for each individual. And it's not just one thing on its own, it's not just a particular diagnosis, family history, stress or psychological factors or the social environment that you're in. It's the unique combination of all those things that are going on for you.
What's really important as we think about these standards is that it's bringing that focus into the design, the development, the delivery and education of learning and teaching approaches to make sure that it is up to date with what's considered now best practice. So it's not just about the content, but also thinking about the way that content is being delivered.
But I think what we always need to do as clinicians is go back to the beginning, which is the patient. Listen to the patient, hear what their story is, and then can we apply the latest science to them?
Welcome to Setting the Standard for Better Pain Care, presented as part of National Pain Week. My name's Nicolette Ellis and I'm Chair of Chronic Pain Australia. Today we're exploring the newly launched Australian Standards for Health Practitioner Pain Management Education, a significant national achievement that will help strengthen pain education and support better care for people living with pain. I'd like to sincerely thank the Faculty of Pain Medicine, our silver sponsor for National Pain Week, for their leadership in developing these standards and their ongoing commitment to improving pain care across Australia. I'm delighted to introduce today's facilitator, Professor Michael Veltman, who is Dean of the Faculty of Pain Medicine. Michael is a consultant pain physician, educator, and leader in pain medicine, who has made a significant contribution to specialist training and undergraduate medical education. Joining Michael are three outstanding panellists: Dr. Noam Winter, specialist pain physician and head of pain services at Alfred Health; Dr. Phoebe Holdenson Kimura, medical advisor at the Australian Commission of Safety and Quality in Healthcare and a practicing GP; and Ms. Kate May, who is a chronic pain advocate, health communications advisor, and board director of Chronic Pain Australia, who brings both professional expertise and lived experience to today's discussion. Thank you for joining us. I'll now hand over to Professor Michael Veltman to begin today's webinar.
Thank you, Nicolette, and thank you to Chronic Pain Australia for hosting the National Pain Week of 2026, acknowledging that the Faculty of Pain Medicine is pleased to sponsor National Pain Week as a silver sponsor. And this is an opportunity for us to explore the new Australian Standards for Health Practitioner Pain Management Education. These were developed to support more consistent, evidence-informed and person-centred pain management across Australia's health workforce. And the standards really respond to a recognised national need. Health practitioners across all disciplines require stronger pain management knowledge, skills and confidence to enact their knowledge. This has actually been run over a number of years in a much broader context. The National Strategic Action Plan was endorsed by the Australian Health Ministers in 2021. The National Strategy was finalised in 2023, and the Australian government-funded project led by the Faculty of Pain Medicine has been going through 2024 and 2025 before the launch this year. The standards were developed through a broad consultation, including with people with lived experience of pain, educators, clinicians, professional bodies, regulators and other stakeholders. You'll hear from some of them today. The structure is really for today is for each of our speakers to talk on some of the reflected or all of the reflected standards, and the discussion will focus on what the standards mean in practice, and then we'll close with the next steps of how organisations can engage with the standards. So my first standard that we'd like to talk about is the patient-centred approach to care, and this is with Kate. And the question I'd like to ask you is, from your personal and professional experience, why do you think a person-centred approach to care is so important when health practitioners are working with people who are experiencing pain?
Thanks, Michael, and thanks for inviting me here today to speak. A person-centred approach is so important because we're all individuals that live with pain, and pain is really complex. What's true for me is going to be a little bit different for what's right for someone else, even if we have similar diagnoses or similar symptoms or similar experiences with pain. It's kind of confusing sometimes, as in my professional role in public health communications. Often in my work, we're driven by population trends and broad public advice. And for me, that was frustrating as someone living with pain, because often broad advice or what's said in one area of research might not be applicable to me as a patient. And sometimes that was hard for me to wrap my head around, particularly at first when I was trying to learn to understand what was going to work for me. A lot of this is because pain is complex, and it's shaped by the biological, psychological, and social um, factors that are unique for each individual. And it's not just one thing on its own. It's not just a particular diagnosis, family history, stress or psychological factors, or the social environment that you're in. It's the unique combination of all those things that are going on for you. That was really important for me when I was first learning about pain, and I could actually start to see, I could map out my own unique biological history of infections, family history, diagnoses. I could map out the psychological and some of the things that were going on for me at the time. And I could map out some of the social things, my understanding of pain, education, supports around me, housing, all those sorts of things. It really helped me understand why something was different for me that might be different to someone else. So, of course, it's important not for me to just understand that as a patient, but for the practitioners that I'm working with to take that approach and see that all those unique circumstances in me or similar patients, and then tailoring an approach that's right for them.
Do you see person-centred care as being pivotal to all of this?
Yeah, of course it is, because you have to apply what's right for the person and listen to them. And I think a huge part of that is actually taking the time to see what's unique for that person and to apply the right care for what's around them and what's available to them. A lot of that means time that you have to sit there and listen. And then I guess the advice that you give has to be accessible and has to be right for that person in their unique circumstance. I guess I think it's always helpful to have an example, and my favourite example when talking about a person-centred approach or even a strengths-based approach is to talk about exercise and my exercise physiologist. Exercise is such an interesting topic and always a great one to chat with fellow people with pain, because exercise can be a really great evidence-based management for some people, and for others it just isn't quite the right fit. Even within exercise, there's so many different types of exercise, and some can flare pain and some can really help. It's a really long process to figure out what's right for you. And I've been going to the same exercise physiologist for years now. They've worked with me, they've sat there and listened, and they've adjusted every single step of the way. I think they've done a really great job at seeing there's not a one-size-fits-all approach. They're guided by their evidence and their practice and their experience, but they always check in with me. They might suggest something and they say, go away, Kate, see how you go, see how you pull up, let's check in next time and see what we can do next. And I think that's a really great example of person-centred care. And it's kept me coming back, every week for 3 years, and it's really helped me a long way in my process.
Thanks, Kate. I think that really does highlight why person-centred care must be more than just an aspiration, but we really need to embed it in the way health practitioners are educated from the beginning. My next question relates to the best practice education. Phoebe, a lot has changed in health education since many of us first trained, and Standard 2 focuses on the best practice education. So can you tell me why this standard is important, and what does it ask education providers to think about?
Thanks, Michael. Yeah, so the way that I think about it is that, we've come a long way, as you've said, in our understanding of pain and how pain's different for each individual and that biopsychosocial approach. But in the same way, I think over the last few decades, there's been a significant change in the way that we think about what good health professional education more broadly looks like. And we've looked from sort of moving from just thinking about that book knowledge to a system of teaching that looks at embedding not just content, so not just knowledge, but also skills and behaviours as we shape our students to be able to, be professionals in their fields. And so I think what's really important as we think about these standards is that it's bringing that focus into the design, the development, the delivery and education of learning and teaching approaches to make sure that it is up to date with what's considered now best practice. So it's not just about the content, but also thinking about the way that content is being delivered. And so when I think about, how not only consumers or patients are individuals and diverse, so are our learners. And so this standard really draws attention to the fact that learners themselves are diverse and have different needs and preferences, and that needs to be designed for and acknowledged from the outset. And so we're thinking about having multimodal approaches to teaching pain throughout the curriculum. And so, yes, that book knowledge is really important and a good, foundation, but equally we're thinking about experiential learning from clinical encounters, group-based learning. There's a lot of role play, I think, that's important in developing communication skills for clinicians, and that interprofessional learning part, which is preparing learners to be able to work well as members of a multidisciplinary team when they're providing care for people with pain. The other thing that I think is really interesting and important in this standard is the recommendation for those with lived experience to be involved in the design and the delivery of pain management education. And for me, thinking back to my time at medical school, those were some of my most powerful encounters, I think, for my own learning, is hearing from people who have experienced pain and being able to hear their own stories and their narratives, because that really brings to life, some of understanding around what that looks like and perhaps the suffering that comes with pain, but also hearing how people have worked through that, and those stories of hope and resilience, I think, are really important for learners to hear. So I think really we're wanting to think a little bit more outside the box in terms of what's considered those sort of traditional approaches to teaching, but also putting emphasis on, as I said, communication, collaboration with patients, partnering with patients, and working towards a coherent approach in education that doesn't emphasise sort of one type of knowledge over another.
So while we've come a long way, there's still a lot of room to keep pushing things forward. Is that right?
Oh, I definitely think so. Yes, and I guess it's acknowledging that these approaches to teaching, these may be very well embedded at some universities or at some colleges, or may have been well adopted by particular educators. But it's about lifting the bar, I think, for everybody, and making sure that that those principles are embedded throughout.
Thanks, Phoebe. So the next principle in the standards is about evidence-based content. And my question really is to you, Noam. Standard 3 focuses on evidence-based content. But from your perspective as a pain physician, what are the most important shifts in how we understand and manage acute and chronic pain, and how are these reflected in these standards?
Great. Thank you, Michael. Look, I think both you and Phoebe alluded to that over the last couple of decades, we've had this massive expansion in our understanding of both the biology of pain, the imaging of pain, our research into medications that may or may not work with pain. But I think despite this, as a clinician on the front line, pain is still largely a very invisible disease. And we now know that to really understand and treat both acute pain and persistent pain, we need to look far more holistically at our patients. And that's what standard number 1 is about. It's about centering the patient in the middle of their pain experience and listening to them, believing them. It's also important, though, that everyone who treats pain, people living with pain, stays up to date with the best evidence in pain management in their own specialty, because these standards apply across all health disciplines. So whether they're a new graduate or whether they've been practicing in their area for 4 decades, it's important that they stay up to date, and that's what Standard 3 is about. Our understanding of the science today is very different than it was when I started as a junior doctor in the late 2000s. Back then, the iPhone hadn't yet been released at that point. And our approach to pain was very, very biologically focused. And there wasn't anywhere nearly as much focus on multidisciplinary management, holistic care. And as a result of that, I think what we've seen is that, taking that unimodal approach to pain actually ended up causing some harm with some of our patients. So I think as clinicians, just as our technology has evolved and we're all using the latest version of our smartphone. I think that's what the same approach that we need to looking at pain management. We need to every so often need to go out there and get the latest version, the latest update in pain management, so that we can get the best outcomes for our patient.
Fantastic. So what you're saying is that pain's actually an exciting field, but the evidence base is now evolving quite rapidly.
Yeah, correct. And it's continuing to evolve. And the amount of research that's out there presented at in national and international conferences, I think the future looks exciting. But I think what we always need to do as clinicians is go back to the beginning, which is the patient. Listen to the patient, hear what their story is, and then can we apply the latest science to them?
Yeah. Thanks, Noam, because that point about keeping the knowledge current is especially important, because pain management science, best practice are just moving very fast and education needs to keep pace. In terms of the fourth standard, reflective practice and self-awareness, I have a question for you, Phoebe. Reflective practice is familiar to most health practitioners, but Standard 4 gives it specific emphasis in the context of pain management education. So I would ask you, why is reflective practice so important when working with people experiencing pain?
Thanks, Michael. So as you said, I think increasingly we're recognising that reflective practice is key for all health professional education, and that self-awareness is a core component of what it means to be a professional and our ongoing professional practice. But I do think that it's especially important when it comes to providing pain care. As Kate said, pain is often complex, and I guess in my experience and in supervising learners, clinical encounters with those in pain, I think, can be challenging as well. And so when those consultations go well, that's a really good feeling, and I think you leave with a shared understanding of what the problem is and a positive way forward. But equally, that's not always the case, and you can be left with the sense that perhaps something could have been done differently, or perhaps a particular message didn't land particularly well, or perhaps we didn't listen as clearly to understand exactly what it was that was the patient's priority in that particular appointment. Now, I think, as health professionals, we're fairly attuned to those cues generally, but what's important around reflective practice is to take the time to not only reflect in the moment as it's happening, but also take the time to reflect afterwards. And often that's best done with another person, not just alone, but another person, to sort of unpack, well, what was it that happened there, and try and make sense of that, and then think about ways that you might want to do try things differently going forward. I think about reflection or reflective skills as a bit like a muscle. For some people, it comes fairly intuitively, and for some of us, it's actually, it doesn't come so naturally. But what we know from health professional education research is that it can be taught, and it's best taught through modelling. But over time, that becomes incorporated into what that person thinks is part of their ongoing professional development. And so I think it is about embedding that in early in health professional education at the undergraduate level, but then continuing to embed it throughout teaching, I think. And then for us as educators, as I said, it's really about providing those intentional opportunities for reflection in the clinical environment. And I think that it is those clinical encounters that are most rich for learning, and to model that sort of honesty, I think, and that candor that even experienced clinicians can find this difficult sometimes, and to sort of come alongside learners together to demonstrate that it's a continual process of reflecting on the way that you approach things. So as I said, I think it's absolutely essential for us to keep growing and developing as professionals in this space. It's not seen as an optional soft skill, I guess, or a non-technical skill as we talk about these things now. But I do think, particularly when it comes to pain management, reflection is an essential part of safe and effective pain care.
Thanks, Phoebe. I think that's a helpful reminder that improving pain care is not just about knowledge. It's also about how practitioners understand themselves and their assumptions and their relationship with patients. And of course, that leads into communication, which is Standard 5. And Kate, Standard 5 focuses on communication, but from your perspective of someone with lived experience, what are the key elements of this standard that you think are particularly important?
Thanks, Michael. And I love a communications question as a communications professional, but it's also, it's so important from a patient perspective and really challenging at times. This is communication, not just in one-off appointments, but over time. And for me, that's been, a journey of about a decade, and the communication that's helped along that journey and sometimes hindered. I think the first point I really want to talk to is validation, and that's a key element of communication, and that's being able to validate that pain is there, that it's real, that you're believed and you're seen, and what are the options moving forward from there. Validation is so important in pain, because if you don't feel like you're seen or you're believed or someone understands that, okay, this is a chronic pain thing going on, then how are you going to manage? How are you going to improve? First, you have to be seen, and you have to have that rapport and relationship with practitioners to be able to take those steps forward. So validation is absolutely essential. The next communication element that I think is really important is listening and having that two-way relationship. Communication should never be just that one way, I'm the professional or I'm the expert, here's what you should do. There's so much to learn when there's that dialogue. And I've learned so much from myself and from other patients as well about pain that I couldn't have learned from a textbook, or I couldn't have necessarily learned from a practitioner. I think there's this vital knowledge that sometimes gets overlooked or missed. So communication in a clinical context or more broadly as well needs to be two-way and needs to be looking at knowledge in different spaces, not just where you might first think that there is knowledge about pain. Yeah, so of course, good communication also means avoiding some of those judgmental or stigmatizing languages. I've been there, and so have so many people in the pain community. We felt dismissed, we felt, oh no, that's not a thing, felt judged. Exercise is something I brought up before. Many people feel judged because they're not able to exercise. There are all sorts of things that you feel judged for, or you feel like are creating barriers, and communication is a way that can break down those barriers and actually set up some options moving forward. I've got a few little nuggets of some of my favorite pieces of communication that I learnt over time, because like many people, I didn't understand what was going on in my body. I didn't understand chronic pain at all when it first happened. And I can look back and sort of see these few little nuggets of communication that set me on a different path going forward. And the first one is so simple, but yet so overlooked sometimes, and explaining the difference between chronic and acute pain. This has been going on longer than 3 months. This has been going on a long time. That means it's a chronic thing, so we've got to look at those pathways going forward. That's just one key piece of communication that makes a real difference. The other one for me, and this may be the case for other people that might be similar to me, understanding that something might not show up on a scan. Pain can't be seen in your blood work, but that doesn't mean it's not there. For me, understanding that I didn't have a structural damage, but I had a functional problem, and that meant that I could go down that pathway of all the different options that might be available when we know it's not going to get fixed by surgery, when we know there's not something in your spine that needs someone to go in there and fix it. Learning that is the pathway that's right for you. And I remember when finally that concept clicked for me, it made things easier moving forward. So there's just a couple of examples of little bits of communication that, when you get them and when you can understand them, actually make a real difference from a patient perspective.
Thanks, Kate. That really brings home to me that communication isn't sort of separate from care, but it's really one of the main ways that care is delivered. The sixth standard is the collaborative approach to care. And my question is to know, Standard 6 focuses on a collaborative approach to care. Can you tell me why collaboration between GPs, specialists, allied health practitioners and the people experiencing pain is so important in pain management?
Yeah, great. Thanks, Michael. Look, I think pain has always been a multi-dimensional experience. It might start with an isolated injury to one part of your body, but we know that after a period of time, it starts to really impact on every aspect of your life. It's there day in, day out. It affects your sleep, your mood, ability to work, our relationships at home. And unfortunately, there's no magic biological medication that can fix that. You need a multidisciplinary, holistic focus to manage what is truly a multi-dimensional experience. I think the thing as the clinician treating people who are going through that is this actually encourages a bit of self-reflection, which is one of our other standards, and it also encourages humility. It says that I can't fix this problem by myself and I need the support of a team and the different expertise that they bring in order to help my patient. And we know that teams work best when they work together towards a common goal, acknowledging that everyone has a different skill set and they all bring something unique to the table with a different role to play. And of course, the other really important member of the team, I think the most important member, is of course the person living with pain. Because I think with being patient-centered, standard one, we need to understand that we can assemble this group of experts, but the patient is the one that has to do the majority of the work. And that's what Kate alluded to with her story about her EP. It was about them working with her, communicating effectively with her to set common goals. And that's what we really should be doing as clinicians. We are there to support, provide guidance, really to help work with the patient to set those common goals, to establish motivation in order to get meaningful outcomes. Because if we don't do that, we don't achieve anyone's goals. So really effective collaboration is a key to success.
Okay, so now looking ahead, what are the next steps for the standards and how can organisations engage with this work?
Yeah, well, great. Well, thank you. So luckily, the Faculty of Pain Medicine has received further Australian government funding to support the implementation and promotion of these standards. And the next phase is actually about helping organisations to understand and use the standards in practical ways. So this will include developing tools and resources to assist education providers, professional bodies, and other organisations to assess their current education and training against the current standards. The faculty will also continue stakeholder engagement across health, education, consumer and policy sectors. We'll be holding a pain education summit. That will take place in Melbourne in October, and that'll bring together stakeholders interested in the implementation and collaboration on these standards. And that'll actually take place just before the Faculty of Medicine's spring meeting, which will be at the first weekend in October. The aim of this is really to support a national conversation about how the standards can be embedded across all health practitioner education and training. Now, I think at the end of this webinar, there'll be a link to the full standards and the online hub, and I think there'll be a QR code that people can link to and contact details for people who'd like further information on these projects.
Thank you, Noam. It's encouraging to see the work moving from development into implementation because that is where the standards can begin to influence education and ultimately care. So I'd like to thank the speakers and to everyone listening to really reinforce this call to action. We now need to help people in pain. So I'd also like to thank Chronic Pain Australia for hosting the National Pain Week in 2026. I thank everyone listening to this for their interest in the standards and improving pain care, and that remind everyone these standards are intended to be used by education providers, professional bodies, health services and others involved in health practitioner education and training. And I would encourage all of the organisations to review the standards and consider how they can be applied to their own programs. I'd emphasise the improving pain management education as a shared responsibility across the health system. And I would invite everyone to access the standards through the QR code that will be appearing shortly and the online hub, and to encourage all of you to share the standards with colleagues and visitors.